This is a case of a nanophthalmic eye that has an axial length of 16 millimeter and has a cataract, and the IOL power was 57.5 diopters. As you see, the eye is very small, it's a little bit sunken, and I'm performing cataract surgery in this case. Usually I give the patient mannitol and Diamox before at least half an hour before surgery to decompress the vitreous. And I do my side ports and inflate it with a viscoelastic, and then the main port. And using a cystotome, I fashion my capsule rhexis, and as you can see, I take it slowly and gently as the eye and the anterior chamber is shallow. It's 2.7 millimeter only, and the structures are crowded, so I try to take it slowly so as to avoid any tears or a runaway of the rhexis and any complication. And after completion of the capsule rhexis, then I perform hydrodelineation, and more that I prefer more than hydrodissection in this case, to give me a shell and to keep the bag inflated even when I take off my instruments of the eye. And then this is a soft cataract, so I just perform a removal by aspiration. I don't use any phaco power, luckily. As you can see here, I'm trying to just push my instruments in the anterior chamber, and as you see, it's crowded. It's barely I can put one instrument in at a time. So I remove the cataract. I prefer to stay in the center and do the aspiration of the lens material, and after that I use the irrigation aspiration cannulas to remove the rest of the cortex and the cortical matter that remains, and it gives me more control, especially in cases of nanophthalmic eyes and short eyes. One of the most important tips to use in these cases is not to pull your hands off the eye simultaneously, and to keep the fluid running or replace it with the viscoelastic, and not to decompress. And as you can see here, I keep my second instrument in the eye as I remove the first one, and I inflate it with saline, and I complete my irrigation aspiration procedure and maneuver to remove all cortical tissue. I then fill it up with, as you can see, I don't pull out my hand unless I fill it up with viscoelastic, and I prepare for the insertion of the lens. Now the lens here is a special design lens. It's 57.5 diopters, and it's a thick lens. I do load it myself in the cartilage to make sure, because this is a special design, it's not replaceable so easy. So just make sure everything is in place. I put a lot of viscoelastic. I try the plunger, how it's smooth, it glides inside the cartilage before I try to insert it inside the eye. And then I move to inserting the IOL in the bag. It's very important to insert it in the bag from the first attempt, because it's these eyes are a bit crowded and it's difficult to tuck it in, and these lenses are thick. It's difficult to tuck in after insertion in the anterior chamber, so try your best to get it in the bag from the first attempt. These kind of lenses usually have this whitening effect once they are placed in the eye due to the thermal effect, and does not affect their performance. They usually clear up by the second day post-operatively, and this is the second eye for this patient that I've implanted such as an IOL, and it gives me excellent results, and it's although it's thick, but it's very smooth to inject in and to load as well. So these are my top 5 pearls for performing cataract surgery in nanophthalmic eyes, small eyes, is to decompress the vitreous before surgery. Make sure that you do not to fill the AC and do not pull your hand out from the eye. Remove it as an earlier stage to avoid the need of a high phaco power. The cornea is so near to the rhexis and to the capsule, and perform it in stepwise approach, and good luck with such similar eyes. And thank you very much. Hope you find this useful.